introduce Professor Hussein Shaisha, Professor of Nephrology and Internal Medicine, Mansoura University, and the dynamo of everything, actually, education, and I don't know, without him what we would have done, actually. I also want to thank him for all what he's doing this. So he's going to be addressing the subject phosphate control in CKD and dialysis, and I'm sure he's going to give us a very updated presentation.
Thank you very much, dear Professor May, for this very kind introduction. We work as a team in education. So before I'm going to discuss the issue of the update of phosphate control in CKD and dialysis, I would like to congratulate Professor Salah Naga for his persistence to make NephroAlex one of the very important meetings. I enjoyed this year the hybrid technique. Congratulations for the excellence of organization, and with ICOM, this is fascinating. Also, I would like to congratulate Professor Hala Wakil, being the head of Alex in Nephrology and Transplant Unit. I hope for Professor Hala all the best, inshallah. And I appreciate the sincere efforts done by Professor Iman Gohari and Professor Muhammad Saeed. You did very nice job and very hard job to be done. So congratulations. I'm always happy to be here in Alex with all my professors and colleagues. And sorry we lost Professor Amr Abeid, we lost him. And we hope that Allah will bless him and to be substituted this dunya by the best, inshallah. To start with the phosphate, phosphate is not a single, it is one part of CKD MBD, but as you know, kidney is the main organ for phosphate excretion. With chronic kidney disease, phosphate excretion may be hindered. This is why, from early beginning, there are compensatory changes by two hormones. These hormones are beta-H, parathormone, and FGF23, trying to push the kidney to excrete phosphorus. But because CKD is progressive, at the end of the day, we may have hyperphosphatemia, with the expense of hyperparathyroidism and many clinical consequences, including cardiovascular mortality and phosphorus. High phosphate is uremic toxin. But as you see here, this is one of recent international data showing there is appreciable percentage of patients who have phosphorus above 6 milligram per deciliter, severe hyperphosphatemia, even in the North America and many countries. Why phosphate is important? As I mentioned, it is toxin associated with many morbidity and mortality. But I'd like to present some ideas from the update. This is an experimental animal model, CKD mice by 5-6 nephrectomy. Hyperphosphatemia is associated with testicular dysfunction and impairment of testicular function. Another important point is cognitive function. The higher the serum phosphorus, the lower the cognitive function, as shown from many mental states. I know all these data are observational studies, but to be put in mind, this is another interesting residual kidney function. We like residual kidney function because it gives the freedom and the flexibility of managing our patients in dialysis. In a study including 13,000 patients, hyperphosphatemia was associated with a rapid loss of residual kidney function, as shown in this figure. The higher the serum phosphorus, the faster the decline of residual kidney function. Bad news. The best serum phosphorus in dialysis is try to be normal. Through 3.5 to 5.5 is the best. If the serum phosphorus is above 5.5, residual kidney function will be declined rapidly, irrespective to the demographics the patient has. Male is not male gender, it is major adverse lower or limb event. Major adverse limb event, as shown from this cohort study, 10-year follow-up. And this is the commentary. The higher the serum phosphorus, the higher the surrogate for peripheral vascular disease and the limb event. So a lot of problem. The most important and crucial, the hyperphosphatemia. The more the hyperphosphatemia, the higher the mortality. This is a new cohort, 17,000 patients. They evaluated serum phosphorus serially over 6 months, and then they calculated area under curve for increase of serum phosphorus. As you see, it may be 0, no change, above 4.5, or up to 0.5 increase, 1 to 2, or above 2. What is the link of this with the outcome with mortality? It is clearly shown here in this slide that the higher the change of serum phosphorus toward hyperphosphatemia, the higher the major adverse cardiovascular events, cardiovascular deaths, all-cause mortality, and trend for non-cardiovascular mortality. Again, so hyperphosphatemia is bad, associated with many consequences. How to manage hyperphosphatemia in CKD and dialysis? The new paradigm shift in the management is 3 Ds. Diet manipulation, using of drugs, either phosphate binders or targeting internal absorption. And for the patients on dialysis, the third D is dialysis optimization. These are the 3 Ds that we use for treating hyperphosphatemia. Regarding diet, to put in mind that absorption of phosphate depends upon the nature of the diet. So if we take part of our diet from plant, this is associated with lower absorption. Why? Because phosphate is bound to phytate, and we don't have the capability to digest phytate. Animal protein, we need animal proteins to avoid malnutrition, but to know absorption from animal protein is high, bioavailability of phosphorus is high. And the third point is in organic additives like soda, prepared foods, canned foods, bioavailability is around reaching 100% without any beneficial nutritional value. This is why we should educate our patients against all these points. This is a very nice study in dialysis patients showing that if we encourage plant diet, we will reduce phosphorus without endangering the nutritional of the patients. So we can even on partially basis encourage plant for dialysis patients. Food additives should be forbidden because it is a hidden source for phosphorus. And food additives, including pH regulators, stabilizer, flavor, color, all these are associated with hidden phosphorus without beneficial effects. The second problem is poor labeling of phosphorus content, that we should do something for this point to read the or to be available. And this is the current guidelines for nutrition from the Kiduki clinical practice guidelines. The same, to be balanced, individualization according to patient preference, to put plant in focus, and to avoid malnutrition through these guidelines, starting from the early stages of CKD to dialysis and even transplantation. We don't like hyperphosphatemia. The second important source for hidden phosphorus, I'm not going to speak about neutral phosphate or glucophos. No. For example, drugs like amlodipine, 10 milligram tablet of amlodipine includes 120 milligram phosphate, hidden source. And if you read the pamphlet, you will find no phosphorus written. This is why there is a call for companies to write the composition of phosphorus, especially for patients on dialysis and CKD. And we can expect, if we treat the patient to buy a new drug and there is increasing of phosphorus out of the control, we can suspect there is phosphorus within this drug, even if it is not written in the pamphlet of the drug. Regarding absorption, what's BITS? BITS, we have 2 pathways for absorption of phosphorus: transcellular and paracellular. Transcellular through sodium phosphate transporter, type 2B, BIT1, BIT2, 3 transporters in the intestinal cell to facilitate transcellular absorption of phosphorus. And the paracellular absorption of phosphorus depends upon sodium hydrogen exchanger. So if we put this slide in focus and look how to control phosphorus. So if we manipulate diet, treating with phosphate binders, This will reduce phosphorus. And then targeting absorption, targeting any of these transporters, and I'm going to discuss these points in the next part of the presentation. Regarding phosphate binders, I like to answer these 5 questions. Can phosphate binder be taken with food? Should be with food, or shortly, immediately before food, to get the maximum effect and to avoid poor consequences. Why would a dose be missed? We should put it a target to avoid non-adherence. If a dose is missed, should it be skipped? Yes, skipped. We will not give the second dose because it will be very cumbersome for the patients. Chewable tablet should be chewed, yes, with the exception of saccharoferric oxyhydroxide, which is a newcomer, can be splitted, yes. Should phosphate binder be personalized? Definitely yes. These are the different classes of phosphate binders, advantage and disadvantage, and I think all of us know calcium and the positive calcium balance, the newer non-calcium based, and the effect on cholesterol and the effect of iron for iron containing phosphate binder. I'm not going to read them. If we compare calcium acetate to sevelamer in this study, this is a very nice cohort study. It is not randomized controlled study. The assumption is sevelamer is beneficial, is associated with better cardiovascular outcome. However, the propensity matching is no difference in cardiovascular, and this is one of the problems in the phosphate binders. Sevelamer, another problem, thorn in the side of sevelamer, it reduces the bioavailability of vitamin K and increase uremic toxin, and we have Professor Shams Sayed always speaking about toxins, indoxyl sulfate and others can be increased by sevelamer. This is the ugly face of sevelamer. Regarding ferric citrate, very nice. This is the meta-analysis, including 16 studies documenting superiority of ferric citrate to bind phosphorus with the second advantage, replenishment of iron. But the problem is diarrhea and feces discoloration. So we have advantages and disadvantages. This is the paradigm of thinking. Hyperphosphatemia, iron deficiency, both of them increase FGF23. And we heard in the morning, Professor Sobhi, about the FGF23. If we treat this patient with ferric citrate, we will hit both of them. We will hit iron deficiency and we hit hyperphosphatemia. So this may be of advantage for reducing FGF23. Again, this is a concept rather than evidence. Saccharoferric oxyhydroxide is very nice, associated with better control of phosphorus, and the more important, it achieves a better control by less number of tablets. So the pill burden is very minimal with saccharoferric oxyhydroxide, but the problem is the cost. Another advantage, it is available in 2 forms, chewable and split one. Both of them are fine, and when the users, it change from the fixed chewable to split, it gives flexibility. And a bonus point for this molecule is nephroprotection. It seems it decreases as well FGF23. Another new player in phosphate binders, the author and scientists trying to find the best phosphate binder. But up to this moment, we have no ideal phosphate binder. BT20, it is combination of ferric iron, oxide, and dietary ligand adipic acid. This combination increases the capacity of the iron to chelate phosphorus. Very fantastic and efficient with low burden. It is tested in phase 2 study, was significantly associated with reducing phosphorus in comparison to placebo with tolerability. If we look at phosphate binders in a panoramic view, the problem is we don't have solid outcome. I enjoyed the Professor Magdi when he said that there is no evidence-based. Yes, there is no evidence-based medicine. To the extent United States, they don't agree, don't approve phosphate binders yet. There is a problem because there are many confounders in the observational studies, and when the phosphate binders are tested in interventional studies, there is a problem and no significant improvement. And the blue line, if you see, the blue line is some advantages, anti-inflammatory, cholesterol, anemia, yes, and the purple line is bad, ugly face. a lot of side effects and adverse, and the cost. And don't, regarding the bill burden is a problem. Why a problem? If I am a patient and taking 9 tablet or 12 tablet phosphate binders, so, and use stress on the phosphate, I can take phosphate binder and leaving ACE inhibitors, other drugs, where they are very beneficial. So this is to put in mind. From binder to absorption, Tinabanoor is fantastic. This is the randomized phase 3 study showing that Tinabanoor is efficient. Don't forget, Tinabanoor is a drug that inhibits sodium hydrogen exchanger, so it reduces the paracellular pathway of phosphate absorption. Fantastic. But again, we are still waiting further evidence because this study is including a number of patients which is not convincing for routine use. And there is signal of safety signals in pediatric age, so it's not approved in pediatric age. But this is good news. The most common side effect of Tinabanoor is diarrhea. This is why it is FDA approved for treating irritable bowel syndrome outside the issue of hyperphosphatemia. So how, if we treat both axes, giving phosphate binders and target absorption, this is the combined trial. We waited this trial, we were eager to know the results because the design is fantastic. Lansanum plus nicotinamide. Nicotinamide targets sodium phosphate transporter. The results were negative. The combination doesn't add anything. This may be a tolerability issue of nicotinamide. So the concept is valid, but the scientists are searching for a good molecule from the safety. EOS789. What is this? This is a molecule that targets all bits. Sodium phosphate, bit 1 and bit 2, so it is BAN transporter inhibitor. This is an animal model study, perfect. Phase 1 human study is encouraging, so we are waiting further evidence. As I mentioned, hyperphosphatemia is within the domain of hyperparathyroidism, and this is one of our Zooms, and we honor that Professor May was with us in this meeting, more than 2 hours discussing hyperparathyroidism. But regarding the drugs working on beta H, vitamin D is not good for phosphate. Either vitamin alpha calcidol, baricalcitol, whatever, they may increase phosphate. But calcium mimetic, whatever the agent, they reduce phosphate. This is another point, but we should think of hyperparathyroidism. What about dialysis? Peritoneal dialysis is of limited capacity to remove phosphate. Hemodialysis is superior to peritoneal dialysis, especially if we increase the dose or frequency. And the best, as you see here, the best is for nocturnal daily hemodialysis. I think it is impossible, Dr. Hisham, to run 6 hours every day. It is impossible. But we learned from Professor Hisham when he stated about the kinetic of phosphate, so the optimization of dialysis is important. In 2 minutes, the idea is Dr. Tariq Tantawi is interested by sodium glucose transporter inhibitors. Is there a problem in sodium glucose? And Professor Magdi Sharawi likes this molecule. And they should like them. Why? Because they are nowadays proven in cardiology and nephrology beyond doubt beneficial. But for phosphorus, this is the problem. Increasing phosphorus, increasing beta H, increasing FGF23, and decreasing active vitamin D. But minimal change. Does it be translated into clinical practice? I don't know. We are waiting further evidence. For circadian rhythm, in comparison to normal persons, if you look, just look at the curve for the control and CKD, you'll find difference. The peak of phosphorus is different in CKD in comparison to normal. Should we use this to give the drugs concomitant with circadian rhythm? We don't know. It is just an idea or new to be followed. If we live in the vicinity of healthy food environment, does this help with hyperphosphatemia? The answer, according to this data, including more than 250,000, no, it doesn't help anything. But the most important is to respect the label of phosphorus and to educate the patient for better nutrition. The most updated study published a couple of days ago improved CKD. One of the unmet needs If we wait until we have hyperphosphatemia, if this is late, should we treat the patient earlier while the process is working about phosphate within normal? This was the rationale of this study. If we start earlier, this will be translated into better outcome. So it's multi-center, double-blind, randomized controlled study using
Dear doctor,
carbonate
your time is up.
and so in comparison to placebo, this is a very nice study. Although the power is not very powerful, but after 96 weeks, no difference in pulsed wave velocity, vascular indices, or calcification. So again, to the extent that the editor wrote binder, blunder. What's meant by blunder? Blunder in Arabic, الخطأ الفادح. هل البايندرز هم ده الخطأ اللي احنا بنقع فيه؟ We don't know. This means that we don't have an ideal drug, and there are a lot of unknowns to be addressed in the future. And this is one of our humble trial. This is a randomized controlled trial including 100 patients to educate them. This is one of the strategies to educate the patient for the healthy style of eating, and does it make a difference? And we found in this study improvement of phosphate control by educating the patients in this randomized control study without endangering their nutritional therapy. So if we focus on the patient preferences, following the evidence, trying to maximize symptomatic treatment, I think this will be within the goals of 2021 World Kidney Day theme, because this is the theme, living well with kidney disease. One of our aims is to enhance education, not only for doctors, but also for all players, doctors, nurses, and the patients. Because I believe in this statement, a doctor is a student until his end. Thank you very much for your attention.
Thank you very much, Professor Hussein. As usual, of course, it's very comprehensive. And do you have any questions, please? Yes, Professor Magdi.
Excellent presentation, Professor Hussein. But I just want you to mention that you have to measure phosphorus in a fasting patient. It should be measured in a fasting patient, especially in dialysis patient, not after food. And this is a very common mistake in many dialysis centers. I think Dr. Hisham agree with me.
I agree with you. And the second point, as I mentioned, serial monitoring of phosphorus. And if we are out of the range, we should increase the frequency, because KDIGO is stated, and from the China there is guidelines how to monitor phosphorus every 6 months, every year, in the beginning, and then every three months, and then monthly on dialysis. If there is hyperphosphatemia and we manipulated the management, either diet and drugs, even we should monitor weekly. Yes, fasting, and if the circadian rhythm become a reality, we may even monitor according to the serum phosphorus. Okay. 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 So this needs further studies to be highlighted, because it seems that everything is controlled from Allah under central and the peripheral clock, from the hypothalamus, everything, even GFR, sodium absorption, and everything is controlled by Allah.
Thank you very much, Professor Shaish. I have a very short comment regarding the phosphorus molecules. It's a very small molecule. It's a 135 Dalton, which is just doubling the urea. But the kinetic modeling is completely different from urea. As well, your phosphorus attain 3 molecules of water, so becoming very large molecule to be removed by dialysis itself. So phosphate kinetics and kinetic modeling has more than 4 pools to be removed, and the kinetics is very different from any other uremic tox. My question, I understand that phosphate overload is present in CKD patient even with normal serum phosphate. So if you're a patient with CKD and normal phosphate, how we can diagnose an overall total body phosphate or a phosphate overload to determine that?
Thank you very much. Regarding the first point, I enjoyed your presentation about phosphate kinetics with us in the Zoom meeting with principles of dialysis. Fantastic. And I advocate everyone to look at your presentation. And just to clarify phosphorus and phosphate, there is a difference between phosphorus and phosphate. We use them interchangeably. Phosphorus and phosphate the same, but actually they are not the same. Phosphorus is the ion that binds oxygen to be phosphate. And if we say we want to eat 1 gram phosphorus per day, this means 3 gram phosphate. So there is some little bit change. Regarding how to know there is a problem in phosphorus and the kinetic of phosphorus before hyperphosphatemia, because we have, as I mentioned in the first slide, we have beta H and FGF23 trying to manipulate to avoid hyperphosphatemia in early CKD. There are some points, some of them is to calculate the phosphate excretion per day, or fractional excretion of phosphorus, or even looking at FGF23 and the parathormone, because it seems that they precede hyperphosphatemia as a consequent mechanism. But what is very frustrating for me is the result of improved CKD trial. It may be of lower power, but it is double blind, including a large number of patients, and at the end of the day, treating the patient while he is normal phosphatemic CKD, stage 3B and 4, no translation into beneficial effects. So this is one of the important points. Even from physiological and academic points, we can know from the early start there is a problem, but they are not accurate. Phosphate fraction excretion of phosphorus is good, but it's not accurate for telling us about the problem of phosphorus. And this is a problem.
Thank you for your elegant lecture, actually, and I have a comment and a question. What about nocturnal dialysis for the hyperphosphatemia? This is one thing. And the other is, maybe iron as phosphate binder is better than the calcium, iron base, because iron is not absorbed, calcium may be absorbed.
So this is what I mentioned during the presentation. I am believing in iron.
You said that iron based.
I am believing in iron as a ferric citrate or the newer ones, or even in the pipeline BT20. I am believing in this molecule. The major problem is the cost, and they will hit phosphorus and iron in one weapon. And the most important is the low bill burden. So yes, I agree with you 100%.
Because they don't hit it, because actually in dialysis patient we are not preferring oral iron therapy because it is not absorbed.
There is a big difference between ferrous sulfate, ferric gluconate, and the molecules which we usually use them for treating iron deficiency anemia and ferric citrate. If I say ferric citrate, as Professor Magdi Sharqawi 1 year ago showed us a very elegant presentation about its approval for treating iron deficiency. So ferric citrate is an exception. It's absorbed and they replete iron. So it is not like the usual iron that we have, like iron sulfate. So this is an exception. So this may be.
Actually, we have to study biochemistry more, because calcium citrate is not advised to be taken. Okay. So ferric citrate is advised to be taken. Can you have the principle behind that?
What is it? Ferric citrate is absorbed. And even before ferric citrate, there was a technology in the pharmacology to improve iron kinetics by putting phospholipids core, and they reached the evidence that oral form of this iron can be equivalent for replenishment of iron like intravenous iron. In CKD or not CKD, this is a new technology.
Please, we should move to the third talk in our session. Thank you.
طيب النازل